All the sorts of things that we had thought we would see with the design, we're seeing in the patients. So we're seeing evidence, that basically very shortly after giving the injection, it's clear that those CD8 T cells are ramping up, the natural killer cells are ramping up, even if they started low. And the patients in our trial are really patients who don't typically have very many other options, unfortunately. When you're a patient with advanced cancer that has metastasized around the body and all the regular therapies you've kind of tried and there's nothing more that you can try, those are the patients that typically will enter the sort of trial, what we call a first in human trial. It's kind of the first time you ever look at the drug's activity. And what we're seeing there remarkably is we have already seen a number of patients who've had responses to MDNA11. We've seen patients who've had dramatic shrinkage of their tumors.
So Dr. Arash Yaveri is a physician scientist with over 20 years of expertise in clinical development and scientific strategy, spanning immuno-oncology, inflammation, and rare diseases. Thank you so much for taking the time.
Great being here, Arpad.
First, I'd like the audience and myself to get caught up with some basic concepts. So what is immunotherapy?
Immunotherapy is a relatively new form of treatment that has been developed for cancer. So the beauty of immunotherapy is it's a type of treatment that actually doesn't directly attack the cancer. What it does is it harnesses the body's own immune system. So these are typically a type of white cell called a lymphocyte, whose job is by day actually to find, hunt, kill, and destroy small tumors in the body. That's what they're actually designed to do. So immunotherapies co-opt those cells and actually facilitate their action. So in other words, enabling your body to be able to clear the tumor itself.
So now let's get into how MDNA11 works.
MDNA11 is what we call a next generation interleukin-2. So interleukin-2 is a cytokine. Cytokine is basically a fancy word describing a chemical messenger. Now, these immune cells have to kind of talk to each other, right? They have to send out messengers that allow them to talk to each other, to be able to message, for example, that you need more immune cells at a certain place, or you need the immune cells to be activated, to be switched on, to be producing things that allow them to kill things like cancer cells. MDNA11 is based on one of these cytokines called interleukin-2. Interleukin-2 is a very, very critical, important cytokine that is effectively, it's a growth factor for these lymphocytes. And we've talked about white cells. I've used the word lymphocyte. Within lymphocytes, we've got different types. People might have heard of something called T cells or T lymphocytes. So this specific T lymphocyte is really the cutting edge sword that actually identifies cancer cells. And remember, Arpad, and for your viewers as well and listeners, that our immune system has got a really difficult job. Its job is to identify the cancerous cell and obviously destroy that, but not to harm the normal cell that could be sitting right next door. Those T lymphocytes need to be able to identify those abnormal cancer cells and destroy them. And to do that, they rely on things like cytokines like IL-2. So what it does is it actually causes them to activate, it switches them on, and causes them to sort of replicate and proliferate. They turn on, and they also produce toxins and things, if you like, that enable them to damage and to destroy those cancer cells. So interleukin-2 is really a very, very fundamental fuel, if you like, that is used by the body to be able to kind of turbocharge, if you like, this immune response against cancer. Now, IL-2 is actually a bit more complicated than that because it does broadly two things. There are, in fact, another group of T cells that do the opposite effect, which kind of calm the immune system. They calm down inflammation, and they're called regulatory T cells. So you've got this kind of yin and yang mechanism that the body has. Now, the challenge here for cancer is that interleukin-2 stimulates both of these arms. So both the bit that inflames the tumor, if you like, and then the bit that will extinguish the immune activity and kind of calm things down. You don't want the latter, ideally, right? You want more of the former.
So basically, the regulatory cell says, okay, guys, the fight is over. Calm down. Let's all
Exactly.
go home. Let's not destroy
Exactly.
anything anymore. And then that's the normal function of the body. But the cancer cell tricks the reg cells to say, guys, it's calm down. Meanwhile, there is a fight that should be happening that is not taking place.
That's exactly right. That's exactly right. Now, the challenge of it is what we've learned with interleukin-2 is that it is a very difficult drug to give on its own. So the interleukin-2 that's approved is basically vanilla flavored interleukin-2. It's basically as you would get from the body that does exactly what we just said. The Achilles heel is several. One is that it stimulates the good anti-cancer cells, but actually it stimulates even better the Tregs. That the body's almost wired to preferentially stimulate the Tregs, which is absolutely what you wouldn't want ideally in this scenario. The second is it's very short acting. When you're administering it to patients, we have to give it very frequently. We have to give it 3 times a day, typically for 5 days back to back, as what we call an infusion. So it's a drug that's given through the veins, and it's an extremely toxic drug.
So how does MDNA differ, MDNA 11, I should say, differ from interleukin 2?
Yeah, this is the key question. So there's three key pieces. So what we've done with MDNA11 is we start with interleukin 2, a normal interleukin 2, and then what we've done is we've introduced certain spelling errors. These are mutations where what the net result on the protein is it can't stimulate the regulatory T cells anymore. We basically disable its ability. It can't bind to the receptor. The other thing that we've done is we've said, okay, what about the other side of the equation? Can we turbocharge the binding and the activation of the anti-cancer cells? So we've ramped that up very, very dramatically. So that's called beta-enhanced IL-2. So this is now effectively a super IL-2, if you like, a kind of a super cytokine IL-2. And then the third element is the short half-life. So what we mean by short half-life is you have to keep giving the drug, remember, 3 times a day. And this obviously isn't very patient-friendly or doctor-friendly, in fact. So what we've done is we've now linked it to another molecule that your viewers might have heard of called albumin. Albumin is something, again, that the body makes, the liver makes, actually. It's one of the most abundant proteins in the body. And albumin does a lot of important things in the body. But for our purposes, the beauty of that is it means it extends the half-life. So in plain English, what that means is you can now give the drug every 2 weeks or every 3 weeks as a single dose, as opposed to every 8 hours, effectively.
So how does the cancer feel about this?
Well, I guess I haven't asked it personally, but we have a clinical trial ongoing. So we're very fortunate actually that we're in the position actually that we have tested MDNA11 in very many patients with different sorts of tumors now, and all the sorts of things that we had thought we would see with the design, we're seeing in the patients. For us, this is very exciting, and it's particularly exciting because we've seen it across a number of different tumor types. We've seen activity in tumors that aren't the same ones that IL-2 was approved for, suggesting that it may have broader applicability, which is important. And you'd think that, right? You think the immune system would have the ability, if you use the right tools, to hit and seek and destroy different types of cancers rather than being bespoke to just one type of cancer or two. And as I say, the other important aspect is it's done it on its own. This is then very reassuring for us at Medicenna to say, actually, look, the drug does really seem to be showing meaningful signs of activity. Again, it's all at a very, very early stage. To allow us to kind of develop it further and, as I say, to test it with some of these other therapies. And at the moment, it's very much in the late stage cancers, but obviously we do use immunotherapies in earlier stage cancers as well. And typically that's kind of another step that we would be looking at to develop next.
Thanks so much for being here.
Thank you so much, Arpan. It's been a pleasure. Thank you to your audience as well. And yeah, absolutely delighted. Thank you for your time.